to her master's in Jewish studies with a certificate in Jewish chaplaincy. Megan, I think a lot of people kind of insensitively say something like, well, despite what she's been through, or what he's been through, they've been very successful. I really resist that. You are naturally gifted, you are naturally talented, and naturally successful in your being, and are commended for all that you do and who you are. And you do live with something that you're going to be teaching us about, but your fortitude is inherent and is natural to you, not even considering what you're going to teach us. So your thesis, Megan's thesis, is entitled The Life of an Arnold Chiari Malformation, 1, Jew, through the lenses of health, chronic pain, and spirituality. And I will be a timekeeper and kind of communicating with you from the back in odd ways.
Hello, everyone. So, as Rochelle kind of hinted on, I do suffer from a very rare congenital neurological disease called Arnold Chiari Malformation. I do want to note that this is not my presentation, that when I had brain surgery, I was actually here at UCLA. So to do my thesis right now here at UCLA, I have become full circle, and it's actually miraculous of God that I am sitting here discussing this with all of you, because there was a point that I had to make a decision whether I wanted to be strolled out of the hospital and live in a wheelchair for the rest of my life, or have surgery and be able to be somewhat of a normal, productive human being. So I'm here with you at UCLA. We're not associated, but we're here at UCLA to discuss this. So as you can see on the screen is, I don't have a pointer, but this is someone who doesn't have Arnold Chiari Malformation. So if you're not diagnosed with it, this is basically what a normal brain looks like. Keep in mind, I am not a doctor, nor have a lot of information about this, but until I am an expert. This is someone who does have Arnold Chiari Malformation. So basically, you can see that this is the brain tonsils. Yes, we do have brain tonsils in our brain. Yes, we do have it in our mouth. But when it's like this in our brain, compared to it's not here, someone like this would need to have surgery. So mine, the first time surgery, it was greater than 5 millimeters. If I'm not speaking loud enough, let me know, I can speak louder. So now I'm going to discuss the ins and outs of Arnold Chiari. So I'm not a number, I'm not a statistic. I'm not a pincushion, I'm a person with feelings, emotions, concerns, but most importantly, I have hopes and dreams that have been crushed by my diagnosis. Be gentle, I've already been through enough. So since you guys are studying to be clergy, it's important for all of us to understand that we're going to be encountered at one time or another with congregants or patients or our walks of life that struggle with any type of chronic pain or any type of disease. So keep in mind, if you, I'm sure all of us at one point in our life or another have some type of headache, make that a million times worse, and that's what I suffer on a daily basis. What is it like to have a very rare neurological disease called Arnold Chiari Malformation 1? I'm going to, acronym it ACM1. That is unknown to most people. What is it like to be in pain on a daily basis? It's not great. So now the origin. So in 1891, Hans Chiari, professor of morbid anatomy and Austrian pathologist at Charles University in Prague, wrote a publication called, it's in French, I'll try my best.
Actually, it's German.
Huh?
German.
German, thank you.
Yes.
My apologies, German. Thank you. Which describes troubling changes in the cerebellum due to hydrocephalus, which is like water on the brain of the cerebellum. Chiari described 3 types of hidden-brain anomaly and increasing severity of hydrocephalus. In 1896, Chiari published a another article that described the 3 types of hidden brain anomaly, but he added a 4th, which was called the cerebellar hypoplasia without protrusion through the foramen magnum. So at the beginning, you saw the screen, it had a circle around it before you had some tonsils coming through. That's what they're referring to. On the left is Arnold Chiari himself. Another doctor that helped found the disease was Julius Arnold. Dr. Arnold was a German pathologist born in Zurich. He described his pathological findings of disease from an infant who passed away shortly after delivery. He published his findings of disease in an 1894 paper. There it is in German again. In 1907, the name of Arnold was added to Chiari's name by Schwab and Gregg in a publication that became the infamous today known as Arnold Chiari Malformation, despite Arnold's meager contribution to the study of the malformation. Today, doctors use the term interchangeably with Chiari malformation. So if you're walking around the hospitals and hear someone who has it, you're going to hear Arnold Chiari or you're going to hear Chiari malformation. Chiari malformations is structural defects in the base of the skull and cerebellum, the part of the brain that controls the balance. Normally the cerebellum and parts of the brain stem sit above an opening in the skull that allows the spinal cord to pass through, called the foramen magnum. When I was little, I described to my pediatrician that it felt like somebody was coming from me from behind. Can you turn around? Go down. From behind and going like this on the top of my head. Is how I described it to my pediatrician. My pediatrician had no idea what that was and transferred me to a child neurologist. Chiari malformation may develop when part of the skull is smaller than normal or misshapen, when forces the cerebellum to push down into the foramen magnum and spinal canal. This causes pressure on the cerebellum and brainstem and may affect human functions controlled by these areas that block the flow of the CSF. So the computer of the human body is the brainstem. The brainstem controls everything. So when you have herniated tonsils that are greater than 5 millimeters, that is when the patient needs to have brain surgery. Unfortunately, as of today, mine is 11.8. So it's hard to see because this is a PowerPoint presentation and it's kind of blurred, but mine is down here. I also have a kink in my brainstem, and I have part of the C2, which is the cervical spine, is going into the brainstem. So I have a lot of, you can say, stuff going on. Unfortunately, I do need to have another 2 brain surgeries in the very, very near future. What causes these malformations? The malformation is caused by structural defects in the brain and spinal cord that occur during the fetal development. This can be the result of genetic mutations or a maternal diet that lacks certain vitamins or nutrients. This is called congenital malformation, is what I have. It can also be caused later in life by the CSF fluid that is drained excessively from the lumbar or thoracic areas of the spine, either due to traumatic injury, disease, or infection. This is called acquired or secondary. So the primary is the most common versus the secondary. Can there people be walking around anywhere and have this disease? Yes, they can be asymptomatic. They would only know if they had a car accident, brain injury, some type of something, and they'd have an MRI. So these are the symptoms of Chiari. I do suffer from some of them. I do suffer from probably most of them. You guys can see, on the screen what it is. It's actually a picture of me in pain. How is ACM classified? There are 5 different types of ACM ranging from type 0 to type 4. A newly found form of Chiari was described by the absence or zero herniation of the tonsils below the foramen magnum. It's called type 0. ACM 0 has the presence of both symptoms and a syrinx in the spinal cord, which is like a cyst type light. Treatment at ACM 0, basically do a routine MRI every 6 to 12 months to see if the herniation grows or the patient becomes symptomatic. Type 1, which I have, happens when the lower part of the cerebellum, called the cerebellar tonsils, extends into the foramen magnum. Normally only the spinal cord passes through its opening, most common form of ACM that most people have. It is usually noticed in adolescence or adulthood, often by accident during examination for another condition or trauma. Adolescents and adults who have ACM but don't have any symptoms initially may develop signs of disease later in life. I was diagnosed at the latter years of age 14, beginning at 15, when I was going when I was finishing my 9th grade year in high school, and immediately had to have brain surgery. Type 2 is individuals with type 2 have symptoms that are generally more severe than type 1 and usually appear during childhood. This disease can cause life-threatening complications during infancy or early childhood, and treating it requires surgery. The cerebellum and brainstem tissue protrude into the foreign magma. Type 2 is usually accompanied by a meningeal form of spina bifida that occurs when the spinal canal and backbone do not close before birth. Type 3 is a very rare and most serious form of ACM. Some of the cerebellum and the brainstem stick out or herniate through an abnormal opening in the back of the skull. The symptoms of type 3 appear in infancy and can cause debilitating and life-threatening complications. Babies with type 3 can have many of the same symptoms as those with type 2, but can also have additional severe neurological defects such as mental and physical delays and seizures. Children diagnosed with type 3 don't usually survive long after birth. You might be called into those rooms and asked to take care of the mothers and fathers when their child is, going to pass. Type 4 involves an incomplete or underdeveloped cerebellum, a condition known as cerebral hypoplasia. In this rare form of ACM, the cerebellum is located in a normal position, but parts of it are missing, and portions of the skull and spinal cord may be visible. Children diagnosed with this type usually don't live long after birth either. These are the conditions associated with ACM. It's hydrocephalus, which is basically water on the brain, spina bifida, which is the complete closing of the backbone and membranes around the spinal cord, syringomyelia, which is most PRA patients have it, I don't, is a disorder with the CSF. It's a filotubular cyst on the syrinx in the middle of the spine, basically. There's Quebecor syndrome, which occurs when a child's spinal cord abnormally attaches to the tissues around the bottom of the spine. There's spinal curvature, which we know is scoliosis. There's seizures. We could be put on the autism spectrum, which doctors did put me on. That's obviously I'm not. Craniosystosis, which is a condition in which one or more of the fibrous sutures is an infant's skull prematurely fuses by turning the bone, thereby changing the growth pattern of the skull. There's migraine headaches. There's pseudotumor cerebra. There's Ehlers-Danlos syndrome, which you might hear on television a bunch of times, and Klippel-Feil. How common is ACM? Studies have shown that the tonsillectomy is as high as 0.5 to 0.7 of the general population. ACM range in the United States as high as 500,000, which may seem a lot, but it's not. 300,000 would mean about 1 in every 1,000 births, which is basically 0.1 of the population have PRA. 1 in 10 are familial. ACM is also associated with other genetic conditions. ACM is found in dogs, a dog, Cavalier King Charles Spaniels. Yep. ACM occurs more often in women than men. Type 2 malformations are more prevalent in certain groups, including people of Celtic descent.
About 7-8 more minutes.
Okay, I'm just gonna speed through this. How was it diagnosed? Before 1977, they diagnosed by postmortem. When the MRI was invented in July 3rd, 1977, they started using MRIs. So the treatment for ACM, the guy in the middle, he is the renowned Arnold Chiari expert for UCLA. In most cases, the only way to do treatment for Chiari is surgery. As of right now, ACM is still on the walk, so whether or not it is genetic. However, recent studies have shown that P13K and AKT have been shown, and also chromosomes 9 and 15. Are they sure? Not yet. How do you explain this to schools, religious institutions, and the people we serve? That every person who has ACM has symptoms that can be less or more severe than others. See if the students have an IEP. Students need assistance and might be afraid to ask all of you for support. Open your hearts, actively listen, engage, and come to an agreement about what the student needs. Have a special committee and make sure your eyes are on that student so the student can succeed. Chronic pain and suffering. People with chronic pain feel if you don't look sick, people might not believe you. Unlike some conditions, pain is invisible, and many people with chronic pain feel like they're suffering and alone. people don't believe them. If someone is wearing a cast, you can see that they are physically hurt. When it's inside the brain, like ACM, body, or spinal cord, people can't see the pain. Feeling misunderstood can be disappointing and aggravating. Not many people understand what it means to live with a debilitating invisible disease on a daily basis. Doing a simple task such as getting up in the morning, taking a shower, eating, etc. are difficult things to do. It takes a lot of energy out of a person to do these tasks and can wipe a person with chronic pain out for days. People with chronic pain feel that they are constantly on the go and need to get the tasks done. They never know when they have the rest, that rest is right around the corner. It's hard to focus and get tasks done. The pain can become difficult to focus on other things they want to do, such as reading, homework, writing essays, sermons, exercising, having a conversation. They are most susceptible to depression, which can lead to suicide. The risk of suicide doubles in patients with chronic pain. Getting a great night of sleep is extremely difficult because of the severe pain symptoms. You don't see it in me because I give you guys a game face, and I always have a smile on my face, because that means everything's going to be okay. What do we want you to know? You sure look really hard to look good. It's not all in our heads. We're not lazy, and we aren't ignoring you. We are not drug seekers. We are pain relief seekers. We need a shoulder to lean on and someone to listen to us. Not everyone can relate to people who have chronic pain. However, it's nice at times to talk with someone so we feel we aren't alone. Keep your ears open, because we need clergy to help us with that. All we really need is your love and support. Sometimes just being present can mean the world to someone who has chronic pain. What Judaism says about pain and suffering. So I took a few things that I wanted to let you guys know that was following my heart. I liked Psalm 69:30. When someone is in pain and affected physically, mentally, emotionally, and spiritually, the pain is awful and one feels that they are in a whirlwind and nowhere to turn. In Psalm 69:30, the person has been afflicted with some type of pain and is hoping Hashem will bring them some peace and comfort. In Judaism, we are in pain or suffering. We turn to Psalms and Torah to find comfort. Praying for someone who is ill, it is customary to recite 36 specific psalms to help find a source of comfort and healing. One of the Jewish traditions to help those who are ill is the mitzvah of Before Holim. The roots of Before Holim are first presented in Genesis 17:11 and 12 and Genesis 18:11 when Hashem visits Abraham after the Brit Milah. So I also discussed the Talmud and Darim 39b. The Talmud 39b explains that a truly empathetic visitor may help lessen the ill person's burden for just a little while. The Talmud tells us that if anyone visits the sick, they remove 1/60th of their suffering. This is only true if the visitor is a Ben Gilo. In Baba Mesa 30b, in regards to the Ben Gilo, it states that the illness doesn't just go away, but it sticks onto the visitor as well. One can go further and define Ben Gilo as one who has similar experiences with the patient who is ill. One can emphasize deeply with him or her. To remove suffering, one needs to align oneself with the sick. Other visitors may relieve some of the suffering. The Ben Gilo understands the experience of the person at a deeper level, either being of a similar age or temperament, and can help reduce the sufferer's distress by 1/60th. In order to establish a healing relationship, the caregiver needs to become a Ben Gilo to the sick and suffering. The caregiver needs to find a point of connection with the ill and meet them at the level where they are at the time. I also discussed Talmud 40a. One shouldn't visit the ill person within the first 3 hours or the last 3 hours of the day, and the patient may be weak in pain or not in the right headspace. These are the times when they also have a shift change in hospital, and according to 40a, to visit the patient during the day when they are alert and ready for visitors. And my journey. How did I get to where I am today? How did my health experience and love for Judaism collide? When was my beginning, my Bereshit, deciding to become a rabbi and chaplain as for life career? My heart is filled with ahava, kindness, rachamim, for others who are in need of support. I worked for synagogues for a time as a bat mitzvah, before I became a bat mitzvah up until 2012. The only thing I knew was working for temples and having lots of medical experiences in and out of doctors' offices, hospitals, you name it. I asked Hashem to help me figure out a way to combine the two fields, Judaism and medical. I always wanted to be a rabbi since the age of 12. In 2012, I was introduced to being a hospital chaplain. I did my first CPE at at Providence Alexander Medical Center. I did my second unit at Kaiser Woodland Hills, where I was the only Jewish chaplain. At the age of 15, I was already providing spiritual care, and I didn't even know it. I provided care to the following patients. I needed ACM surgery at UCLA. Doctors relied on me to help guide patients and families through the surgeries. Yes, this was before HIPAA. They gave my grandmother care as she was passing teenage congregants when they didn't want to talk to clergy. I guided my friend's aunt whose son was diagnosed with ACM a few years ago, and continued to give care to those who need emotional and spiritual support. I would like to give a giant thank you for all of you for listening to this thesis presentation. I would like to thank the AJR board, especially those who are in here, Rabbi Gottlieb, Rabbi Rochelle Robbins for giving me the honor Master Rabbi Murad degree and allowing me to make my lifelong dream of becoming rabbi possible. I want to thank my advisor, who's not here, Rabbi Greenstein, and my reader, who is here, Dr. Judy Aronson. Thank you to Robin Fetterman for reeling me in when I couldn't make this huge commitment. I want to thank our board chair, Mark Chapman, Marlene Cantor, for everything, for being there for me and always believing in me. Thank you to Lauren Goldner and Aaliyah for everything you do. I want to give a huge thank you to my wonderful dean, Rabbi Rochelle Robbins, for believing in me and always being there at every step of the way.
Symptoms that were described, specifically the pressure of feeling like you're being pushed down, how could that be seen as being a symptom in other such diseases? Because it just seems by itself a very broad condition that could be like from a neck injury or something else, as opposed to AC, one of the versions of ACM.
So when you go into a hospital and you're describing your symptoms to the doctors will evaluate and you probably do a CT or an MRI. When they do the MRI, that's when they will see this. When there's people walking, there could be any one of us walking around the room right now have ACM and don't even know it because we're asymptomatic. So how does it compare to other diseases? You know, other diseases have their own symptoms that go along with it. Anybody else? That?
I wanted to, actually not a question, I just wanted to make a comment that it was really an honor to have you as a classmate in morning into dancing with Rabbi Brenner.
Likewise.
I really love learning from you and really just a big moment of this.
Likewise, thank you. Anybody else?
Your family and the support systems they had, those period of unknown diagnosis and dealing with and going through with you and not with you. If you could talk a little bit about that?
Yeah, I'm fortunately, for those that do not know, I'm one of 6 children. I have 13 nieces and nephews. I have one other nephew that suffers with NF that is not related to Chiari, however there was a case. I unfortunately have a huge, big family and family friends, not just besides my temple families, but I have all of AJR family as well. And I take it day by day. You know, I call out on the people that I need to call out on. I have a huge Rolodex of everybody I know to count on, and I'm fortunate about that.
So you mentioned briefly about being able to support someone in your community who's had a relative going through a similar disease. I was just curious whether there are currently any support systems for that type of disease within the U.S. or within the Jewish community.
Yes. So I am on the Facebook Arnold Chiari site, and there are other sites that are around that do have this. I'm very active and I let them know who I am and what I have, and so they just kind of count on me to give them information. Thank you to AJR for allowing me to do this thesis, because this thesis has allowed me to write a book, and doctors have been pushing me on a daily, weekly, monthly, yearly basis to graduate so I can get this book out. because this will become literature and my legacy later in life. And it will become another support thing for somebody to look at.
Incredible. Amazing.
I was struck by your question about support, and one thing I want to say about Megan in particular is that she not only receives support, Megan is the rock in many people's lives, and a huge support to her extended family, our community. You can see, that she's offering support here. So I think that was a very good question, and I wanted to, elaborate on that.
Thank you.